Hello, and welcome to today's webinar, CT Virtual Histology, Real-World Histology-Based Solutions for CT-Derived Plaque Analysis, in partnership with Elucid and Cardiac Wire. My name is Brian Casey. I'm Managing Editor of the Imaging Wire. Got a great program for you today. We're going to start with a panel discussion about new solutions for plaque analysis from CT scans, which is making it possible to predict and identify cardiovascular disease earlier than ever. Then we'll open it up for questions in the second half of the webinar. You can ask a question at any time using the Q&A button at the bottom of your screen. Our webinar speakers are Kevin Mathews, Senior Vice President of Marketing at Elucid, Dr. Victor Marinescu. Dr. Victor Marinescu is a cardiologist at Midwest Cardiovascular Institute in Naperville, Illinois. And Amy Pyke, Senior Vice President of Market Access at Elucid. Everyone, thanks for being with us today.
Brian, thank you very much. This is Victor Marinescu. I'm excited to be here with my background in advanced imaging.
Great. Good to have you.
Thank you so much, Brian. It's a pleasure to be here and looking forward to our discussion today.
Thank you, Brian. Look forward to the discussion and also the Q&A that we get in the second half of the webinar.
All right, very good. So let's get started. So we're going to hear right now from Kevin. Kevin, you're going to talk a little bit about some of these solutions for cardiovascular plaque analysis and what's available. So let's hear about that.
Thanks, Brian. I'd like to take a couple of minutes and walk the audience through a demo of Elucid's products. Our plaque composition product is commercially available today. In a few minutes, I'll be showing our FFR-CT. Just note, our FFR-CT is not currently commercially available. But for the sake of this demo, let's assume that I'm a cardiologist and I've ordered an analysis of one of my patients with Elucid. I've sent the CT over to Elucid. They've completed the analysis, and they send me a notification via email that the plaque analysis is complete, ready for my examination. Alternatively, I can just log on to the Elucid software, and I can see all of the patients that I've sent over for the analysis. I either click on the link or I click on the patient, and it brings me to the same view. And it's what you see here on the screen. It's a 3D model of the patient's arteries, and you can begin to see the plaque analysis as it's overlaid with the vessels. It's important to note that Elucid's ground truth for plaque composition is based in histopathology. We categorize plaque in three types, as color-coded here. Blue is calcified plaque, orange is non-calcified matrix, and red is lipid-rich necrotic core. And as I look at the 3D model, I can obviously rotate it and spin it and gain different perspectives. I can see some plaque build up on the right system, but I also think this is probably more interesting here on the left side, where I see a significant amount of initial view of plaque. So on the Elucid software, anywhere I click on the 3D model, it updates the location on the corresponding views, the straightened MPR, the curved MPR, the oblique, and the axial view. So looking at, again, the 3D model here, and on the left side, as I'm looking at this particular area, I'm immediately drawn to the fact that there is a stenosis that's surrounded by lipid-rich necrotic core that's relatively near a tight section in the lumen. I immediately wonder, could this be a higher risk lesion since I see so much of the lipid-rich necrotic core? The Elucid software allows me to walk up or down through the vessel. And again, it corresponds with each of the views. It also, by using the mouse wheel, I'm able to rotate the segment on its axis 360 degrees. And interesting noting here is that this particular patient may not have a high volume of total plaque volume per se, but the type of lesions that the patient has does include quite a bit of lipid-rich necrotic core and even some calcified areas that I can see as well. And it's incredibly important to focus on these individual lesions as incidents happen at the lesion level. So, of course, total plaque volume does give good information, but the lesion level is where you're going to assess the potential risk of rupture. Another interesting feature of the Elucid software is the ability to turn on or off different plaque types. So for example, if I only wanted to look at lipid-rich necrotic core distributed throughout the coronary tree, I can actually turn off all plaque types, and then I'm left with the segmentation that Elucid's analysts created on this report. I can even turn off that segmentation to bring me back to just the raw CT. But it's important to note, by giving users this ability to really take the CT back to the raw CT, our goal in doing that is to not only be the most accurate, but to be the most transparent. We want you to know where the calculations are coming from. We want to give you the ability for you to review this information and for you to confirm that you agree with it. And importantly, we want you to be confident knowing that our segmentation, for example, has gone through a rigorous process that has been reviewed through quality control checks, including by an MD. And as I've mentioned, our plaque composition analysis is trained and validated against histopathology. And we're uniquely able to characterize LRNC, lipid-rich necrotic core. And we want you to know that this has a very high correlation with histology based on the studies that we've done. And you know where this information is coming from, and that it's going well beyond traditional Hounsfield unit measurements alone. Now, with that, I'm going to toggle over to the FFR view of the same tree. And as I look at this at a high level, I certainly can see some FFR-CT changes on the right side that are interesting, but I want to continue to focus on the left side where I was earlier, since that's what I've been looking at. And as I do a couple of measurements here, I can see an FFR reading here of around 0.9 and one maybe here of 0.78. So technically, this would be in the gray zone. And it's important to note that the numbers, of course, are useful, but there's not much context around that. And this is a traditional limitation of FFR-CT. The context upon which the FFR drops really does matter. Now, other methods for calculating FFR-CT may use fluid dynamics, which really focus on the lumen dimensions in order to make the determination, and then use mathematical properties to solve for that. But from what we understand from numerous studies before us, is that the type and the amount of plaque does impact endothelial function, and lipid-rich necrotic core does have the greatest impact. It's important to understand that endothelial function, endothelial function, and to understand its impact on the vasodilatory capacity. And to do that, you need to understand what type of plaque is in the vessel wall. And it's important to note in this example we were looking at on the plaque earlier, is that the type and amount of plaque is actually what's driving the reduction in FFR-CT. And as you'll see in what we were looking at here on the plaque composition before, the FFR-CT is dropping in response to this lesion that is full of lipid-rich necrotic core. If this lesion were full of, say, calcified plaque, there wouldn't be a significant of a drop. It's the LRNC, the lipid-rich necrotic core, and its inability to vasodilate as well that's impacting this drop. So with Elucid, not only do you understand where the drop is coming from, but you're able to use this information to make greater clinical decisions. So in other words, in this instance, not only do you understand that there is a drop, say from 0.9 down to 0.78, and even though it's in the gray zone, this could be, in fact, a high-risk plaque with a meaningful stenosis in the presence of LRNC that is fairly close to the lumen. And in realizing this may be a patient that I move to the cath lab more urgently. And as I make that decision to send them to the cath lab, I have the information that may help in the procedure, such as the stent size, the stent location, or making sure that I don't land a stent in a pool of the lipid-rich necrotic core, potentially causing a peri-procedural complication within itself. And because the plaque composition analysis and Elucid's FFRCT, they're derived from one another. These two measurements are always going to be concordant. It's not going to be a situation where plaque is calculated one way and FFRCT is calculated in another, causing you to have potentially discordant results. So we believe this will give providers a new level of data from which they can make patient-specific treatment decisions. Thank you.
Great. Thanks, Kevin. So now we're going to hear from Dr. Victor Marinescu. Dr. Marinescu has been using some of the Elucid solutions, and he's going to be presenting a couple cases. Dr. Marinescu?
Thank you, Brian. I'd like to share with you guys our experience here at Midwest Cardiovascular Institute with our plaque analysis product. So I'll start with a couple of case presentations. I think I've heard this on several occasions, the question, are we there yet when it comes to coronary CTA and its ability to detect early coronary artery disease? In my humble opinion, there's no question that the unique strength of coronary CTA is its ability to non-invasively discern with good confidence non-obstructive from obstructive coronary plaque. And the last 10, 15 years have really made this sort of possibility due to the advancement in the field of advanced imaging, a lot of it driven by advanced imaging software. In terms of quantitative coronary plaque analysis, this can be hopefully help enhance patient risk stratification, improve patient outcomes, and eventually intensify prevention therapies. To that end, it's not surprising to me that the updated coronary artery disease reporting data system, or the CAD-REDS 2.0, emphasized the importance of reporting overall plaque burden when cardiologists report coronary CTAs for individual patients. To me, the more important message is that this reported information should be used in providing clinical recommendations to the patients. So with that in mind, I'll start with the first case. This is a 66-year-old patient that was from out of town and actually new to our clinic. He had no prior cardiac visits with any cardiologist and had his hypertension and borderline hyperlipidemia treated through his BCP office. He presented to us with a new onset shortness of breath, which was concerning for anginal equivalent. The patient was unable to perform his usual exercise. He had a very strong family history, with his father having had open heart surgery for multivessel coronary artery disease at a relatively early age. This is some of his labs and medications. His lipid profile suggested a total cholesterol of 203. Both the LDL at 123 and Lp(a) were elevated. For this, he was being treated with amlodipine for his hypertension, but was really just undergoing lifestyle changes with no lipid-lowering therapy or aspirin. When we calculated his 10-year ASCVD risk, this calculated in a moderate range at 7.6%. The decision was made to image with coronary CTA the patient's coronaries. We felt that this was appropriate as a first test for evaluating anginal equivalence. Here I show you representative images of his LAD territory, which had a proximal focal area that beyond the calcified plaque showed a relatively at least moderate, if not moderate to severe narrowing. The RCA, on the other hand, the image on the right, suggests more of a soft fibrotic plaque that was not interpreted as severe in terms of the stenosis severity. This was the actual interpretation of the CT, with the read being that of a focal proximal LAD stenosis with a severe greater than 70% lesion not excluded, just proximal to the first diagonal branch. This really highlights a little bit the limitations of coronary CTA. When there's a lot of dense coronary calcium, I tend to give a read that says cannot exclude at times severe stenosis. And then we rely on these post-processing tools like FFRCT to tell us whether there's any sort of functional significance to the lesions. Because of the significant plaque burden, in particular in the LAD and RCA, we also felt appropriate to assess this CT with plaque analysis for individual plaque burden. The other cardiac anatomy was within normal morphology for the CT technique. And the FFR came back. This showed an abnormal LAD value with a proximal 0.65 value at the level of the stenosis. The circumflex and RCA territory had normal FFRCT values. Based on the patient's clinical presentation and these findings, the results were discussed with the patient, and he underwent an elective coronary angiogram. I will show you representative images of the left anterior descending artery, which once again shows a very focal narrowing that my interventional partners agreed with the assessment after they did additional IVUS interrogation of the lesion. Ultimately, this patient ended up with a short stent in the proximal LAD. And we also had the results of his plaque analysis that I am sharing here with you. In red, I have highlighted the feature that shows the lipid-rich core through the Elucid package. And this shows really a lipid-rich core burden of about 2.9%, relatively small to the overall total burden of 229 millimeters cubed. These are individual screenshots of the coronary arteries, starting with the left main and left anterior descending artery, and in particular in the LAD, and that area that was proximal to the first diagonal branch where the stent ended up being placed. There was a relatively high burden of predominantly non-calcified plaque. And also the RCA suggested an area in the proximal segment that had this lipid-rich core. These findings were discussed with the patient. I think the take-home message from this case, first off, being able to evaluate the plaque with the plaque analysis tool allowed us to see the extent of the lesion, and in some ways helped with stent sizing selection in the LAD. But the take-home message towards the patient when I saw him in follow-up, more importantly, I was able to focus with him on the area in the proximal LAD that suggested a higher risk. Now, in my opinion, sharing this information with the patient really highlighted the importance of continued aggressive risk factor modification. And also, in a way, gave us a bigger picture of his entire coronary artery tree and potential implications for his future cardiovascular health. I will jump to the second case presentation. This is actually one of my colleagues who's a recently retired primary care physician. She's pre-diabetic, who was forced into early retirement due to a more systemic autoimmune disease that had nothing to do with her cardiovascular health. I had known her for several years now and was helping with her treatment of her hypertension and hyperlipidemia. You can see that her total cholesterol, which was being managed with a low-dose statin, was acceptable range with a total cholesterol of 197 and LDL of 97. Patient was a relatively aggressive antihypertensive regimen, being a physician herself. She was on losartan, Farxiga, as well as recently started on Ozempic. When she last presented to my clinic, she had new onset chest pain. This had both typical and atypical features. Her gait was very limited, in large part due to balance issues, which made, in my opinion, the decision easy in terms of the testing modality to be used. We ended up deciding to pursue the coronary CTA. I will share with you some of the relevant images Here you see highlighted in red focal area as well as the previous case in the proximal LAD with both calcified plaque as well as soft plaque with some extraluminal remodeling. The left circumflex coronary artery was completely normal, at least to my visual assessment of the CT. And I saw a relatively high calcified plaque burden on the RCA, which is the image here on the right. The interpretation of the CT that I shared with the patient was that of mixed plaque that was noted in the proximal LAD as well as in the mid and the distal RCA, with moderate 50 to 69% stenosis not excluded in these regions. We did once again ask for the functional assessment with FFR-CT analysis, which in her case was reassuring. All the values did not fall below the normal range, but in her, because of her risk profile, I was very interested in the plaque analysis in terms of identifying individual plaque burden and potentially change for treatment management. So I will jump right in and share these PDF files with you. Here you see just a big picture view with the individual vessels in a straight multiplanar reconstruction at the top. And then color-coded, you have each individual vessel with its plaque burden. To me, this adds an extra layer to how we treat our patients. A lot of my partners, myself included, in the past use a calcium score as a tool to identify early plaque. That has its own limitations that we all know about. I think being able to use these automated quantitative plaque tools really makes us very efficient to identify individual plaque burden. And you can see that here tabulated on the bottom of the screen. The patient had a high plaque burden, similar to what I had interpreted visually in the LAD territory as well as the RCA, with slight concern for lipid-rich core in the LAD territory, albeit with a relatively small plaque burden relative to the total score of 227. These are the individual components, which is how we use to assess and report these studies when we do our analysis after the actual interpretation of the CTA. And in particular, on the left side of your screen, you see the distribution in the LAD with a small lipid-rich core burden. This data was shared with the patient, considering that she's pre-diabetic with cardiovascular risk. I considered this high plaque burden on the quantitative analysis added additional discussion between me and the patient in terms of treatment options. She was initially intolerant to higher statin dosing due to her gait limitations and exacerbation from the medication of these. The decision was made to start her on a PCSK9 inhibitor, which lipid profile is now pending in the fall. I emphasized with her, obviously, the importance of dietary and lifestyle changes, which were already relatively well controlled. More importantly, in terms of the take-home message to the patient and in this guy's presentation here, I think that the adoption of coronary computed tomography angiography is growing in the United States. I've been experiencing this myself in the last 10 years here in Chicago. I can say that in our clinic, coronary CT is a first-line test for individuals who first present with chest pain and known coronary disease. Now, with this growing use of CTA, there's now increased interest in prognostic importance of atherosclerotic plaque volume. Throughout my training in residency and fellowship, so this dates back to more than 10 years ago, I myself have toyed with these manual tools for plaque segmentation. But the reality from these tools is that from a clinical and practical standpoint, these are labor intensive and make clinical implementation quite difficult, if not limited. This is where these artificial intelligence-enabled quantification, which we're discussing today, allows clinicians to hopefully better interpret CTA images and do it so more efficiently. Plaque analysis needs to be considered in risk-benefit discussions with individuals who are at high risk. And ultimately, these decisions need to be integrated into clinical decision-making together with the patient. And this concludes my slideshow. Here I have the references for the presentation.
Wow, Dr. Marinescu, those are some really fascinating results. Let's dive into this a little bit more in detail and talk about how exactly you're using this tool in clinical practice. Now, to what extent do you think knowledge of plaque composition will impact a physician's diagnosis and therapeutic decisions over time?
Yeah, it's a great question. I think that the second part of the question is most important in terms of how will it affect it over time. There's no question. I myself, have used and delved in these tools throughout my short career so far. But I'm very excited about my partners who are becoming more and more intrigued by the possibilities of this. I think that being able to assess plaque burden over time and intervene at an earlier date is going to be key to treatment and prevention.
Yeah. And so how do you decide which patients are going to get plaque analysis?
Yeah, that's an individual decision for our readers. Typically, we use the guidelines for that, and in particular, we refer to the CAD-RAD's a recent update on their recommendations in terms of interpretation and reporting that really should focus on individual plaque burden as well. In my personal experience, I typically use it in individuals who either have an overall visual, so subjective, relatively high plaque burden, and certainly at least mild evidence of coronary artery disease with stenosis on the CT images when I interpret them.
Interesting. So do you feel histology-based plaque composition analysis is more relevant or actionable than plaque analyses that aren't histologically based, and why?
That's a great question. It's nice to key in on that, and I don't think that the answer we have the answer yet. I mean, I individually can give you my own feelings on this, and I certainly think that being able to validate the plaque analysis with the histology tool really gives you a unique perspective on an interpretation of some of these lesions. So that is the reason why at this point we use this tool for our individual plaque analysis for our patients.
Wow, Dr. Marinescu, that was some really fascinating clinical information about this solution. But as a lot of healthcare providers in the U.S. know, you can have the greatest clinical solution in the world, but reimbursement is such an important thing to actually get clinical use. And Amy, you're going to talk about the solution from a reimbursement perspective. Can you walk us through the history and how to code for CTA and this plaque analysis tool?
Sure. I'll be happy to, and kind of review the current reimbursement landscape as we see it today. So yeah, I wanted to just go through the reimbursement disclaimer, just saying that all the information is gathered from third-party sources. The information can change, and the billing and coding is up to the discretion of the physician. So the AMA established temporary codes for the coronary plaque analysis assessment back in 2021, and 4 new temporary codes were established to report the non-invasive coronary plaque analysis temporary code 0623 through 0626T. So this family of codes describes the imaging tool that analyzes the coronary plaque to assess the severity of the coronary disease of the coronary vessels derived from the coronary computed tomographic angiography, which is a CCTA. So the codes that we have are the 0623T, which is the global code that is all encompassing. That includes the physician doing the analysis and also the interpretation and reporting. There's also CPT code 0624T, that is a code that is just used for reporting the data and the transmission. The 0625T is reported for this data from the coronary analysis, the CTA, and then the 0626T is a report for reviewing of the analysis, the interpretation, and report that the physician does. So you always have to report the CCTA separately with the CPT code of 75574. So that's the CTA code. And then for doing the coronary plaque analysis, that's when you would use the 0623 through the 0626 temporary codes when you're doing the coronary plaque analysis. You would never report the 0623T in conjunction with the 0624 through 0626T because the 0623T code is the global code. Effective in January 1st, 2026, the AMA made a new category code for the coronary plaque analysis, and that code is 75XX6. The description of that code is quantification and characterization of the coronary plaque to assess the severity of the coronary disease derived from the augmentative software analysis of the data set from a coronary computed tomographic angiography with the interpretation report by a physician or other qualified healthcare professional. So that's a descriptor of a code. The final code number will not be effective until, again, the first of the year. And until that time, the 4 temporary codes need to be reported depending on what is being done.
Now, Amy, can you talk a little bit about the payment levels for 2025 for the codes when they're performed in the physician office or an imaging center, and then talk about maybe how it's paid in the hospital setting?
Sure. So for the physician imaging center, the payment level for the CTA, if it is done in a hospital outpatient setting, is $357. If the physician is doing it in their office, they would do in a professional setting, like in a hospital, a physician office connected to a hospital, that reimbursement would be $109. And if the physician is doing it in a non-facility, such as their office or freestanding imaging center, that reimbursement for the CTA is $318. Now, in terms of the coronary plaque analysis, for right now, in the physician setting and in the imaging centers, with the reimbursement right now, Medicare is reimbursing it on a case-by-case basis. That's why we have carrier priced. So the reimbursement, some of the MACs have on their fee schedule, others do not. So that's why we mentioned it's carrier priced. For coronary plaque in the hospital outpatient setting, it's a little bit different. There's no assigned APC for the global of the 0623T code. And same with the 0624, that's already packaged in the descriptor of the code. But if it's being done in a hospital outpatient, the 0625 code, the reimbursement is under the APC of 1511, which the reimbursement is $951. And for the 0626T code, there's no APC assigned to that code. In terms of the hospital, if they're doing this in a hospital setting, we need to make sure that hospitals are reporting the appropriate revenue code. So in addition to the CPT codes, along with the charges for the individual covered service, we need to make sure that if they're doing it in the hospital outpatient setting, that they're utilizing the revenue code 0489 for the CCTA services when appropriate. In the hospital outpatient setting, this increase is temporary because each year Medicare reviews the utilization of the code, and we need to make sure that hospitals are reporting the right revenue code because that could affect the reimbursement down the road. So currently, the hospital reimbursement in the APC setting is at $357 for the coronary CTA. So we just want to make sure that hospitals are incorporating the appropriate charges on the claim form when submitting that into Medicare.
And Amy, can you talk about payer coverage and the medical necessity criteria that need to be reported?
Sure. So currently, with the Medicare coverage, we have received great news. Earlier this year, Medicare came out with a local coverage determination to cover coronary plaque analysis, and that includes the 5 MACs. The only 2 MACs that are not covering, or which I highlighted in red, those states, is Novitas and First Coast Service Options. So in those 2 jurisdictions for Medicare, we know that they're reimbursing and paying. They just do not have a local coverage determination. I mean, eventually we may see these 2 jurisdictions tag on to the other MAC's LCD, but in the meantime, they are reviewing on a case-by-case basis. So we need to make sure with the Medicare LCDs that are in place, and those are Noridian, NGS, Palmetto, and within those states, we need to make sure that the appropriate documentation is submitted. But in the following LCDs, they do have medical necessity criteria and coverage requirements in place for the coronary plaque analysis. And that is when using the CCTA with the coronary plaque, it's considered reasonable and medically necessary as a diagnostic study when the patient has either acute or stable chest pain with no known coronary artery disease and is eligible for a CCTA. And the CCTA classifies the patient as either intermediate risk or they have CADS, RADS 1, 2, or 3. And the cardiac evaluation is negative or inconclusive for acute coronary syndrome. So those are the requirements right now. The LCD will spell this out and state it out. There are also limitations that need to be, obviously aware of. And those are, the software to perform AI must be FDA cleared or approved, and it must not be considered reasonable and necessary in the following clinical circumstances. And they list out some of those non-coverage criteria for limitations. But also, there's documentation requirements. So we want to make sure that, the accounts and physicians are following the appropriate documentation and requirements that are needed in order for the coronary plaque to be covered. Just recently on the commercial side, we've received good news with eviCore, who is the radiology benefit manager for several payers such as Aetna, Cigna, and United Healthcare, and some of the Boost plans. They updated recently their coverage criteria for coronary plaque, which includes the Elucid PlaqueIQ, and that is going to be starting October 1st. So there will be coverage for eviCore North. Also, United Healthcare just recently came out with their updated coverage guidelines to cover coronary plaque analysis. That goes into effect as well in October 1st of this year. So now we've been working with societies and pursuing other large payers in a coordinated effort along with our industry partners and our societies. Now, in terms of the commercial landscape, we want to make sure that commercial payers, are abiding by, the requirements. And we're working with our customers if they have any questions around the prior authorization. This is the first step that's very critical to ensuring reimbursement. So we want to make sure that our customers are calling to verify prior authorization before the service is done and rendered, because if they're not, that could result in a prior auth denial or a claim denial as well. So we recommend that with a prior auth, they include a letter of medical necessity, the patient history, physical, the CTA report, a completed prior authorization form, and making sure if they do receive verbal or any confirmation from the commercial payer that they have that documented. Now, in terms of the commercial payer appeals, Elucid has a reimbursement hotline that can support our customers with any denials related to prior auth or an appeal. So we can walk the customer through the appropriate steps in order to appeal and get that claim overturned, and what's the necessary documentation, as well as steps needed in order to get that claim and that appeal overturned. There's different levels of appeals depending on the different payers. They do peer-to-peer and internal reviews first, and then if that gets denied, then typically they will send it out for an external appeal, and that is managed at a state level. And, they would go through that appeals process externally as well.
Good stuff. Amy, what kind of resources are available to help providers, work through the reimbursement process and make sure that they can get reimbursement?
Sure. So we have a number of tools and resources that can help support our customers and providers with prior authorization. We have appeals templates, reimbursement guides, and we have our designated provider access line. We call it our Elucid PAL, and that is our dedicated reimbursement line, which is at reimbursement@elucid.com. They could either email us or call us. We have a designated phone number, or even text us if they have a question or a concern or issue related to a prior auth denial, or they have a question if a certain commercial payer is covering. We can address all those questions through our provider access line.
All right, Amy, thank you so much for that information on reimbursement. Getting paid is so important in U.S. healthcare today, so it's great to have those resources available. We now have time for Q&A from the audience. Please click on the Q&A button at the bottom of your screen and type your questions in. And we will have Dr. Victor Marinescu of Midwest Cardiovascular Institute, Kevin Mathews, and Amy Pyke of Elucid answer your questions. So we will be right back. And here we are. So I'd like to thank everybody for attending. We do have some time for some questions. And so I'd like to throw one out to Kevin first. Kevin, can you walk us through the workflow for the Elucid plaque analysis and kind of how, if I were a provider of cardiac CT, like how would I access this technology? How would it work?
Yeah, good question, Brian. And for the person who asked the question, it's actually quite simple. And the setup, I'll explain it in two phases. One is in the initial setup, and then in the actual transmission of a case. But for the setup, it's really as simple as doing a standard DICOM connection. We use a secure Intelerad or Ombra gateway that receives scans from a customer's PACS, and then we return the completed analysis through the same pathway. The installation of that gateway is really quite simple. In our experience, it can be done in about 30 minutes. And if a customer is already using Intelerad or Ombra, which many people are already customers of that service, the process can take as little as 10 minutes. So it's just they see a scan they want to send the analysis on, push it to Elucid over the DICOM connection, and then we return this scan to them.
So it's a 10-minute turnaround?
No, the 10-minute is for the
transmit. So what would be the total? What would be the total turnaround?
The turnaround time, we guarantee 24 hours, but our actual turnaround time is much, much less than that. We're seeing it in the low single digits in terms of turnaround time. And
are there? Oh, go ahead.
No, I'm sorry. Go ahead.
Are there any specific image acquisition requirements for this plaque analysis?
So there are no specific image acquisition requirements for Elucid. We adhere to the SCCT and ACR image acquisition standards and guidelines. And we want to make sure when we're setting up a new customer, we'll work closely with the customers we want to do some quality checks. So we want to make sure that we're able to receive and process their scans in a high quality fashion. So no specific scanning requirements, but regardless, we always go through this quality onboarding step with new customers.
Perfect. So we got a question from Dr. Yankelevitz. When you say histology correlated, does that mean do you mean actually correlate coronary artery plaque with CT images? And what are the slice thickness ranges that this technology can perform for this analysis?
Sure. So the slice thickness, again, this is by the SCCT guidelines. We can process anything less than 1 millimeter. And in terms of the histology, the histological validation, so Elucid's validation was done in a carotid model. So we took CT images working under the direction of Dr. Renu Vermani, a world-renowned histopathologist. We took CTAs of a series of carotids. Patients were undergoing a carotid endarterectomy, and those tissue samples were sliced, stained, put under the microscope, and then the CTAs that had been taken of the carotids were compared to the actual histological examination under a microscope. You do that hundreds and hundreds of times, and that's the basis of the validation where we're able to say we're seeing this on CTA. Is this from a histological basis?
Okay. A couple of questions from Dan Sider, and I think these are probably directed to Kevin. Can the plaque analysis values and images from Elucid be attached to the imaging study or report after analysis for future reference?
They can, and I would actually hand that off to Dr. Marinescu. I think he's regularly using them in his reports.
Yes. For us, it's been relatively smoothless. We're able to download the PDF files, and what we do is we actually incorporate them within our reports. And we incorporate the table, pretty much any part of the report that we obtain from Elucid is easily then pasted into our clinical reports.
Very good, very good. So the second question, I'm very interested in the comment by Kevin on FFRCT based on plaque analysis. Is that information used to complement flow simulation, blood flow simulation, I'm assuming? What does the ground truth look like, and how are the characteristics of the endothelial function modeled and used to inform the FFR calculation?
That's a really good question. So first off, Elucid's FFRCT that we're working on is not based on computational fluid dynamics at all. It's based on the plaque characterization and the arterial structure. The type of plaque and the amount of plaque impacts the endothelial function, with LRNC having the greatest impact. So our model is trained on CTA that's paired with invasive FFR, and then it's validated with CTA and blinded invasive FFR. But it uses these properties of plaque and arterial structure to derive the estimate. That allows us to be consistently accurate, even in heavily diseased vessels or tortuous vessels and other challenging scenarios, without utilizing flow-based assumptions.
Another question from Dr. Yankelevitz. Wonderful technology. How small can the lipid-rich core be to be detected, and is it threshold-based?
Great question. Another great question. So in terms of spatial resolution for detecting LRNC, it would be the same as this spatial resolution for the scanner used, which would generally be less than 0.6 millimeters. And so effectively, we can detect LRNC down to the size of a voxel.
Wow, that's amazing. So I have a question for Dr. Marinescu, and specifically on how this technology, this plaque analysis technology, is affecting your conversations with patients. Because, you mentioned coronary artery calcium during your talk, and you talked about some of the limitations there. Do you feel like when you go to a patient and talk to them and show them their plaque analysis results, is that more impactful than maybe some of the more traditional tools like CAC? And have you seen them maybe take it a little bit more seriously?
Yeah, no, that's a fascinating question, and I think patients in general are much more engaged. I had an early clinic this morning, and I actually did that with a couple of my patients. And I think a lot of what I do as a non-invasive preventative cardiologist is, a disease prevention. And I feel like a life coach a lot of times with these patients. And when they have a visual, evaluation and assessment, just being able to see at all this information, the patients really, you can see it that it piques their attention and they're much more involved in their care.
That's great. That's great. Kevin, do you have any comment on that?
No, I think he sees it every day. I trust his opinion on it. I smile about the life coach thing because this is there's so many aspects beyond just the medical aspect. You're coaching and directing a patient how not only what have we seen on the test results, but then what can I do about it? So that really resonates.
And we're giving patients the tools to change their behavior and also to see the impact of their behavior, because I feel like it's probably pretty impactful when you have someone come in and say, well, you've got these issues, you've got this plaque buildup. And then if they do change their behavior, come back again and see an improvement. I think that would probably be really impactful. Once again, would like to remind our audience, if you have any questions, please use the Q&A button at the bottom of your screen. We do have a few more minutes of discussion here. Amy, I'd like to shift over to the reimbursement side. If you can talk, you talked quite a bit about how the reimbursement scenario is improving for tools like this, and we've seen that Medicare and commercial payers like UHC are covering coronary plaque. Do you think we're going to see other payers follow suit, and is the reimbursement situation going to maybe loosen up a little bit for providers of this technology?
Yeah, it's a great question, Brian. And yeah, I mean, it's wonderful news on coverage to date with CMS's Medicare local coverage decision that came out several months ago. And with a recent announcement of Evacor and our largest payer, United Healthcare, which will be covering for all product lines here in October. It's phenomenal news, and it speaks to volumes of this technology and the importance of it for preventing cardiovascular disease. So I think we'll continue to see payers expanding coverage and see continued clinical evidence evolve. We are working alongside with the societies to broaden commercial coverage and guidelines with their support. And it's a process, as with all new technologies, to get 100% commercial coverage. But I think we're really off to a great start, and we'll continue to work with the payers and the radiology benefit managers to gain coverage.
Yeah.
So,
are they receptive to it? Are the societies receptive to it?
Yeah, very, very receptive, very supportive. And I think, working in tandem with industry partners has been very beneficial as well. But we ask the physicians what they can do on their part is if they do get a prior auth denial or an appeal that may come up, we do have a reimbursement support line, as I mentioned, that can help with facilitating the process of appealing to the commercial payer if that does happen. So we do offer that support.
Very, very good. Well, getting paid is so important in U.S. healthcare right now. Question from an attendee. I think this probably might be directed to Kevin. Are patient scans included in the Elucid algorithm? If so, can patients have their data excluded on an individual level?
They are not currently, so there's no reason or no ability for the patient to have it excluded, but it's not included.
Okay. And we've got another question here. Either for maybe Kevin or Dr. Marinescu. What type of physician is best to order the test, and which types of physician can interpret the results? Is this mostly for cardiologists to order, or could you see a primary care physician ordering this as well?
I can take that question, Brian. We've done this for 10 years here at MCI, and for us, we prefer that this is a test that generally is done through a cardiologist office. Now, I very frequently have close discussions with our referring physicians. In fact, one of my clinic patients this morning was someone who was interested in this plaque analysis tool. So we keep everyone involved. But certainly it's a test that's generally speaking interpreted by a CT capable of reading physician. or accredited physician. And we prefer that it's done with a cardiologist ordering it. Now, I'm just giving you the example in our clinic. We do have at the hospital CT scans that we read that occasionally get sent from outside ordering physicians, including primary care physicians. My personal opinion is that, because you go over so much information and there's so many things that you need to go over once you do a CT scan, it is better to have the patients first meet the cardiologist before any of these tests are performed. But I don't think that necessarily is the case in other places.
It sounds like this test could be kind of a jumping off point for conversations about lifestyle changes and behavior modification and things like that. Kevin, can you talk a little bit about how Elucid's technology differs maybe from some of the other plaque analysis solutions out there? Because this is an emerging segment here. How are you guys a little bit different?
Yeah, it is certainly an emerging segment. We've seen a lot of activity in the space, and candidly, physician interest is really growing at the same speed. And I think the histological basis is the main differentiation of Elucid's platform. Other plaque composition products are using Hounsfield units to where many physician readers have made reads and identified, for example, a low attenuation plaque area. You do that many, many times, and that builds the basis of the validation of other products. But as we know, there can be considerable reader variability just within the same reader, and certainly across a pool of readers. So we believe that using the histological basis that I described earlier is the most important differentiator in our plaque composition, and then in the future in our FFRCT.
Great. A couple more follow-up questions before we close. Kevin, how does Elucid handle analysis where there's a stent or some kind of artifact in there?
Yeah, so the way we handle that is obviously we can't see through a stent, just like the CT can't see through a stent. So Elucid will do the analysis up until we encounter the stent. So if the stent is a bit more distal in a particular vessel, we will be able to do the analysis up the proximal section of a branch. So we would go up until we encounter the stent or the artifact, and then we stop the analysis. So we would return back to the physician as much of the completed analysis as we could until we got to the artifact.
Okay. And how complicated is the IT integration that from an IT perspective, how complicated is it for a healthcare provider to integrate this into their existing systems?
Yeah, and I mean, I touched on this a little bit earlier, but it's really, really quite simple. And it's not just me saying that. We actually hear that from users who have gone live. It's really as simple as setting up a standard DICOM connection, and that's where I was talking about earlier, Brian. The 10 minutes. It can be as little as a 10-minute exercise with IT. If someone's already a customer of Intelerad or Ambra, it's very easy. If they're not an Intelerad or Ambra, then we would just need to get them set up on the gateway, which allows the secure connection, the secure pushing of cases to Elucid, and then the returning of the cases back to the physician.
All right, very good. Well, I think that concludes our program. That's all the questions we've got. I'd like to thank Dr. Victor Marinescu of Midwest Cardiovascular Institute, as well as Kevin Mathews and Amy Pyke of Elucid. And most of all, I'd like to thank everybody out there who took time out of your day to attend our webinar today. Thanks so much. This will be available on demand later on, and we'll be sending you information on how to access that shortly. So thanks, everybody. Signing off for the Imaging Wire, my name is Brian Casey.